Hello everyone, this is Anthony Chan. Welcome to my lecture series on essential medical liver pathology for trainees and any pathologists interested in liver pathology. The previous two lectures covered all important pathological features in response to various liver injuries. Many of these changes are not unique to one disease and can occur in various conditions. This lack of specificity makes it difficult to diagnose the exact cause of liver damage based on a single pathological change. Therefore, we need to combine different pathological changes into a specific histological pattern. Correlating this pattern with clinical, biochemical, serological, and radiological information usually yields an accurate diagnosis or a list of differential diagnoses. There are many histological patterns. Major histological patterns can be categorized into four main categories: hepatic injury, cholestatic injury, steatotic injury, and vascular injury. Let's start with the hepatic injury. The first pattern is acute hepatic necrosis, characterized by severe hepatocellular necrosis with insignificant inflammatory infiltrate and fibrosis. Panacinar necrosis features necrosis of the entire acinus or lobule of the hepatic parenchyma. There is no significant inflammatory infiltrate. Another example of panacinar necrosis is accompanied by a minimal amount of inflammatory infiltrate. This is an instance of panacinar necrosis with accompanying hemorrhage. When we encounter the acute hepatic necrosis pattern, we have to consider drug-induced liver injury, non-hepatotropic viral hepatitis, and vascular disorders, including Budd-Chiari syndrome, sinusoidal obstruction syndrome (SOS), and shock. Non-hepatotropic viral hepatitis is hepatitis caused by viruses that do not primarily target the liver, such as herpes simplex virus (HSV) and adenovirus. These viruses can cause liver inflammation and damage, often as part of a systemic infection or due to the immune response they provoke. This table lists common drugs and toxins presenting with acute hepatic necrotic pattern histologically. These drug or toxin reactions are usually intrinsic or predictable in cases in which they are dose-dependent, for example, paracetamol carbon tetrachloride. We could look up offending drugs or toxins associated with liver injury in textbooks or PubMed. Nowadays, we are much more convenient to look up an updated online resource for drug-induced liver injury, LiverTox. It is produced by the National Institute of Diabetes and Digestive and Kidney Diseases (NIDDK), part of the National Institutes of Health (NIH). It offers detailed information on drug-induced liver injury, including the effects of prescription and over-the-counter medications, herbal products, and dietary supplements. It includes comprehensive descriptions of the clinical features, mechanisms, diagnosis, and management of liver toxicity associated with various substances. A similar database in mainland China, Hepatox, provides drug-induced liver injuries associated with traditional Chinese and herbal medications. The Drug-Induced Liver Injury Network conducted a nationwide prospective study in the United States and analyzed 899 patients with confirmed drug-induced liver injury. Antimicrobial agents are the most common type of drug associated with drug-induced liver injury, followed by herbal and dietary supplements. Both account for over 60% of all cases. Another nationwide retrospective study of nearly 26,000 patients from over 300 medical centers in mainland China found similar results. It identified antimicrobial agents, traditional Chinese medication, and herbal and dietary supplements as the major causes of drug-induced liver injury, accounting for 53% of cases. Notably, traditional Chinese medication and herbal and dietary supplements alone made up more than a quarter of the cases. Hence, herbal medicine and health products should always be considered as potential offending agents leading to drug-induced liver injury. Variability is a fundamental aspect of drug-induced liver injury. This variability can be seen in the types of drugs causing the injury, the time of onset, the clinical presentation, the clinical outcome, and the histological pattern of the liver biopsy. Factors such as genetics, underlying health conditions, and concurrent medication use contribute to this variability. This example demonstrates acute liver necrosis caused by paracetamol, characterized by extensive zone 3 necrosis with minimal inflammatory infiltrate. Drug-induced acute hepatic necrosis typically presents abruptly with a latency period of up to 2 weeks. This is an instance of acute hepatic necrosis caused by ferrous sulfate, characterized by extensive zone 1 necrosis with ductular reaction and sinusoidal congestion. While most drug or toxin-induced hepatic necrosis results in zone 3 or panescinal necrosis, a smaller proportion leads to zone 1 or 2 necrosis. The specific zonal location of the necrosis may be linked to the underlying mechanism of injury. Acute hepatic necrosis associated with herpes simplex virus is characterized by residual hepatocytes containing ground glass intranuclear viral inclusions Caldry B with chromatin imagination. This thrombosed hepatic vein is linked to perivenular hemorrhagic necrosis and sinusoidal dilation. Budd-Chiari syndrome encompasses a range of diseases associated with hepatic venous outflow tract obstruction, regardless of the level or cause of obstruction. Cardiac and pericardial diseases, as well as sinusoidal obstruction syndrome, are not included in this definition. Acute sinusoidal obstruction syndrome involves hepatic vein obstruction with subintimal fibrin deposition, leading to extensive zone 3 hemorrhagic necrosis. This condition, previously known as veno-occlusive disease or toxic sinusoidal injury, is strongly linked to the use of chemotherapeutic agents and radiation. The second pattern is the acute hepatitic pattern, characterized by prominent lobular inflammation, varying degrees of hepatocellular necrosis, hydropic degeneration, and cholestasis, all occurring without significant fibrosis. Varied degrees of lobular inflammatory infiltrate could be present and should be clearly noticeable in the acute hepatitic pattern in contrast to the acute hepatic necrotic pattern. Portal inflammation may also be observed in acute hepatitis, but it should be less prominent than lobular inflammation. The extent of hepatocytic damage varies with severity, and spotty necrosis is frequently observed. Confluent necrosis in the perivenular region is not also uncommonly found in acute hepatitis. Another example demonstrates perivenular confluent necrosis accompanied by cholestasis. Bridging necrosis is present in more severe cases. In addition to spotty necrosis and lobular inflammation, hepatocytes frequently undergo hydropic degeneration in acute hepatitis. Hydropic hepatocytes with spotty necrosis and an apoptotic body are shown here. When encountering the acute hepatitic pattern, we have to consider drug-induced liver injury, autoimmune hepatitis, acute hepatotropic viral hepatitis, and relapsing viral hepatitis in immunocompromised patients. Wilson disease should also be included in the differential diagnosis of any young patient with acute hepatitis, as it accounts for 6 to 12% of all patients with acute liver failure referred for emergency transplantation. This table lists common drugs and toxins presenting with acute hepatitic pattern histologically. These drug or toxin reactions are typically idiosyncratic and unpredictable, occurring independently of the dose, for example, anti-tuberculosis agents and statin. This is an example of antifungal-induced acute hepatitis featuring mild lobular inflammation, faulty of spotty necrosis, apoptotic bodies, and mild cholestasis. Twin cell plates are clearly demonstrated, indicating active regeneration. This is a case of fulminant acute viral hepatitis A with extensive bridging necrosis. The remaining hepatocytes show prominent hydropic changes and form islands or nodules. This example of autoimmune hepatitis shows perivenular confluent necrosis. Many hepatocytes also demonstrate hydropic degeneration. Up to 17% of cases of autoimmune hepatitis have perivenular confluent necrosis, with or without typical portal and periportal changes. Sometimes central vein endothelitis can also be present. Autoimmune hepatitis with perivenular confluent necrosis is typically linked to higher histological grade, lower histological stage, lower frequency of autoantibodies and serum immunoglobulin, and more severe liver function impairment, including fulminant hepatic failure. Differentiation between autoimmune hepatitis and drug-induced liver injury is a common question on the request form from clinicians when they send a liver biopsy from a patient with acute liver function derangement in a hepatitic pattern. Emperipolysis, hepatocellular rosette formation, as well as portal and lobular plasma cell infiltrate are histological features favoring autoimmune hepatitis. The distinction between drug-induced liver injury and autoimmune hepatitis is challenging due to the lack of reliable diagnostic tests. The diagnosis is mainly based on clinical and serological evidence. A particular challenge is that drug-induced autoimmune like hepatitis can be indistinguishable from idiopathic autoimmune hepatitis. Studies on drug-induced liver injury show that 3 to 8.8% of cases may be categorized as drug-induced autoimmune like hepatitis. In 30% of these cases, there may be signs of hypersensitivity, such as fever, rash, and peripheral eosinophilia. Over 40 different agents have been linked to the development of drug-induced autoimmune, like hepatitis, as summarized in this table. This diagram illustrates the algorithm for approaching suspected drug-induced autoimmune, like hepatitis, in clinical practice. You may notice that immunosuppression can be considered for both idiopathic autoimmune hepatitis and drug-induced autoimmune like hepatitis. Severe drug-induced autoimmune like hepatitis usually responds well to high doses of steroids, much like severe idiopathic autoimmune hepatitis, if treatment is started promptly. Sometimes only during follow-up can we differentiate between autoimmune hepatitis and drug-induced liver injury. In drug-induced liver injury, steroids can be discontinued without relapse, whereas genuine autoimmune hepatitis will almost always relapse if immunosuppression is stopped within a few months. Therefore, it is advised to try steroid treatment and closely monitor the patient during steroid tapering and potential withdrawal in uncertain cases. The main characteristic of the acute hepatic pattern is the lack of significant fibrosis. However, evaluating fibrosis in cases of acute hepatitis can sometimes be challenging. Bridging necrosis in more severe acute hepatitis might be misinterpreted as bridging fibrosis. In the previous lecture, we discussed differentiating between bridging necrosis and bridging fibrosis. Several histological features generally indicate bridging necrosis. Firstly, the bridging region appears more congested and hemorrhagic, with numerous steroid-laden macrophages. Secondly, ductular reactions occur within the bridging region rather than at the parenchymal-stromal interface. Thirdly, the trichrome stain shows a distinct two-tone appearance, with darker staining in the residual portal tract and central vein wall and lighter staining in areas of recent collapse. Fourthly, the reticulin stain reveals a condensation of residual, loosely aggregated reticulin fibers. Lastly, the Orsin stain does not highlight the presence of elastic fibers. Similarly, in acute hepatitis, the portal tract can be expanded by inflammation and ductular reaction, potentially creating a misleading impression of significant portal and periportal fibrosis. To avoid overinterpreting fibrosis, particularly advanced fibrosis in cases of acute hepatitis, it is crucial to recognize the presence of prominent lobular necroinflammatory activity and numerous hepatocytes with hydropic degeneration. In such cases, we should consider consulting colleagues or, better, a liver pathologist before diagnosing bridging fibrosis or cirrhosis in a liver biopsy showing marked lobular activity. In equivocal difficult cases, we should acknowledge our limitations and honestly comment that the assessment of fibrosis may be inaccurate in the current liver biopsy with marked necroinflammatory activity. Recommend follow-up and correlation with liver elastography after liver function normalizes. Let's move on to the third pattern, the resolving acute hepatitic pattern, which may appear relatively normal without significant inflammatory infiltrate, cellular damage, or fibrosis. However, the PASD stain reveals a number of steroid-laden Kupffer cells. There is no significant necroinflammatory activity in the resolving acute hepatitic pattern. Significant fibrosis is also not demonstrated in the resolving acute hepatitic pattern. Steroid-laden Kupffer cells are readily found in the PASD stain. The resolving acute hepatitic pattern is actually a minor form of the acute hepatitic pattern undergoing resolution. Two major considerations are idiosyncratic drug-induced liver injury and acute self-limiting viral hepatitis. The final pattern in the category of hepatic injury is portal inflammation, which may also be known as the chronic, quote-unquote, hepatitic pattern. Since there is a significant amount of material to cover in this particular pattern, I'll stop here to keep the current lecture concise and not overwhelming. Thank you for staying with us for another lecture in my series on essential medical liver pathology. I hope you found the information presented today to be both insightful and practical for your studies or clinical practice. Your continued participation and dedication to learning are greatly appreciated. See you later.